I'm Dr. Gene Jose, Department of Radiology, University of Miami, Medical Director of the Lennar Foundation Medical Center. We're here to introduce you to the fundamentals of musculoskeletal ultrasound imaging. I'm joined by Louis Payro, Ultrasound Supervisor for the Lennar Foundation Medical Center, and Nikhil Patel, medical student of the University of Miami School of Medicine, that will serve as our patient. Thank you.
Hey everyone, this is Richard Wang, one of the radiology residents. Today I'm going to be going over basic MSK ultrasound of the elbow. First I'll go over some MSK ultrasound basics, and then I'll go over the anatomy and technique, evaluating the lateral, medial, anterior, and posterior elbow. We'll end on some pathology examples and a video demonstration. This is for educational purposes only. I have no financial disclosures. Because of the various position and orientation of the structures, you want to reference the probe relative to the tendons, ligaments, and muscles in long and short axis rather than coronal, sagittal, and axial. For tendons and ligaments, because of the internal fibrillar orientation, you'll see multiple parallel echogenic lines. This is an ultrasound of the normal Achilles tendon at the bottom left in both long and short axis. For muscles at the top right, they're usually hypoechoic with interspersed small echogenic fibroadipose septae, and this is an example of short and long axis of the gastrocnemius muscle. For nerves, the nerves themselves are dark with low echogenicity surrounded by bright epi and perineurium. They have a fasciculated appearance, and this is a cross-sectional view of the median nerve. Again, these are the transducers that we use for MSK ultrasound. For evaluation of the elbow, we'll be mainly using the middle linear high-frequency transducer. And just to go over anisotropy again, tendons and ligaments have fibers in parallel arrangement, so the sound beams have to be perpendicular for optimal reflection. So small deviations can make it seem like there's a tear when there isn't. At the lateral elbow, you want to evaluate the common extensor tendon and the lateral collateral ligamentous complex underneath. The elbow should be flexed and internally rotated. First, check the common extensor tendon, then deep to that you can see the radial collateral ligament or RCL, and if you go more posteriorly, you can see the lateral ulnar collateral ligament or LUCL as it sweeps under the radial head to attach to the ulna. Sometimes it can be hard to distinguish the extensor tendon and the underlying ligaments. On ultrasound, the images at the top right show the common extensor tendon with the straight arrows. The mid-right show the arrowhead pointing to the common extensor tendon, and just deep to that is the radial collateral ligament. And at the bottom right, you can see as you move more posteriorly, you can see the LUCL. The star shows anisotropy at the proximal aspect of the LUCL as it begins to make its curve posteriorly around the radius. The main thing to evaluate at the medial elbow is the common flexor tendon and the underlying medial collateral ligament, also known as the ulnar collateral ligament. Specifically, you want to evaluate the anterior band of the ulnar collateral ligament, which is attached to the sublime tubercle of the coronoid process on the ulna. The elbow should be as externally rotated as possible while keeping the elbow extended or slightly flexed. On these ultrasound images, you can see the arrowheads pointing to the common flexor tendon origin and the arrows which are pointing to the anterior band of the medial collateral ligament. At the anterior elbow, the main structure to evaluate is the distal biceps tendon. So you want the elbow extended, and you want to follow the biceps tendon to the insertion at the radial tuberosity in both short and long axis views. The top ultrasound image is a short axis view. The arrowheads show the biceps tendon, and note how close in proximity it is to the brachial artery marked by A. and the empty arrow next to that is the median nerve. The bottom images have an empty arrow as the biceps tendon as it travels to the radial tuberosity, and the S marks the supinator muscle. At the posterior elbow, the main structures to evaluate are the triceps tendon and the cubital-tunnel and ulnar nerve. The triceps has three heads, the medial, lateral, and long. The lateral and long converge to form a common tendon, and the medial head directly attaches to the ulna and forms the deepest layer. The top right image shows the triceps insertion. To evaluate the ulnar nerve in the cubital tunnel, the elbow should be extended and the arm internally rotated. Dynamic movement can help determine if there is subluxation. At the bottom right images, the arrow shows the ulnar nerve and the asterisk the triceps tendon. These are examples of distal biceps tendon tears, best visualized on long axis and appears as an anechoic or hypoechoic discontinuity of tendon fibers with or without retraction in surrounding hypoechoic fluid. On the left image, there's a chronic partial tear of the deep portion of the distal biceps tendon denoted by the straight arrow. There's isoechoic granulation tissue filling the gap and a small amount of fluid tracking proximally. The anterior fibers, the curved arrows, remained attached to the radial tuberosity. See the normal fibrillar appearance of the proximal intact distal biceps tendon denoted by the small arrowheads in contrast to the scar remodeled tear denoted by the asterisk. On the right image, this is an example of a long axis ultrasound image of a complete rupture of the right distal biceps tendon at the level of the myotendinous junction, with a balled up tendon denoted by the arrow. These are examples of lateral and medial epicondylitis. The left image shows lateral epicondylitis. The extensor carpi radialis brevis tendon is almost always involved. There's severe tendinosis of the right common extensor tendon. Long axis images show the common extensor tendon origin with thickening and marked heterogeneity and numerous calcifications, along with hypoechoic intrasubstance tears throughout the tendon. On the right image, there's medial epicondylitis. There's severe tendinosis of the common flexor tendon origin. The long axis ultrasound image shows marked thickening, hypoechogenicity, and heterogeneity of the origin of the right common flexor tendon, with multiple anechoic intrasubstance tears. This is an example of tendinosis and partial tear of the common extensor tendon. You can see thickening of the common extensor tendon leading to the lateral epicondyle with an anechoic focus of tear at the arrow. These are examples of ligamentous injuries. On the left, there's a long axis image showing a partial thickness chronic remodeled tear of the proximal ulnar collateral ligament with a hypoechoic scar and coexisting superficial injury of the common flexor tendon. At the top right, there's a tear of the LUCL, the lateral ulnar collateral ligament. Long axis image shows a hypoechoic fluid-filled gap that represents tear at the LUCL. The bottom right shows a full thickness tear of the RCL, the radial collateral ligament. Long axis ultrasound image shows a full thickness tear of the right radial collateral ligament with the hypoechoic fluid-filled gap. There's also some overlying chronic calcific tendinosis of the common extensor tendon. You can also evaluate for elbow joint effusion and synovitis. On the left, it's a long axis image showing anechoic fluid filling the left olecranon fossa with elevation of the hyperechoic joint capsule and pushing the posterior fat pad. On the right, it's an ultrasound image of the left anterior elbow joint with moderate hyperemia. You can also evaluate for intra-articular bodies. On the left, there's a long axis ultrasound image that shows a hyperechoic intra-articular body denoted by the arrow with surrounding anechoic joint effusion in the olecranon fossa, as well as posterior displacement of the posterior fat pad. On the right, this is an example of biceptoradial bursitis with a distended right biceptoradial bursa surrounding the distal biceps tendon. This is an example of full thickness tear of the triceps tendon. The arrows show an anechoic region leading to the olecranon where the triceps should insert.
evaluation of the elbow, the patient is placed with the arm adducted and the elbow flexed to 90 degrees. A linear transducer is used. I like to begin my interrogation by looking at the common extensor tendons, which occur along the lateral aspect of the elbow. I interrogate them both in long axis and then in short axis. Also along the lateral aspect of the elbow, we will see the radiocollateral ligament, and then scanning more posteriorly, we will see the lateral ulnar collateral ligament. Next, we will then interrogate the medial side of the elbow, and we will look at the common flexor pronator tendon origin and interrogate that both in long axis and also in short axis. We can also see the ulnar collateral ligament along the medial aspect of the elbow in long axis. Next, we will interrogate the antecubital fossa. We will begin looking at the biceps brachii by starting in a transverse fashion, scanning all the way inferiorly towards the radial tuberosity and looking at the tendon. And then we will turn and interrogate the same tendon in long axis, looking for biceps tendon rupture. Lastly, we will look at the back of the shoulder and the triceps tendon insertion. We will follow this in long axis and also in short axis as it inserts into the olecranon. The posterior aspect of the shoulder, of the elbow, is also a great place to evaluate for elbow joint effusions.